Welcome, everyone. We'll just give a few seconds for everyone to join, and then we'll begin. Let's begin. So good morning, good afternoon, good evening to everyone. Welcome to the first EPIWIN webinar of 2025 that's focused on civil society organizations, on the public health risks of avian influenza and civil society organizations' role. This is in coordination with the WHO CSO Commission, the Faith Network, the Youth Network, the Global Health Cluster, and others, and of course, the Global Influenza Program and the Community Protection Team here at WHO. We decided to have this webinar because avian influenza continues to pose a significant global public health threat. And in the last few years, as you know, it's been detected in a variety of mammals and spread geographically. And there were reports in the US of outbreaks amongst dairy cattle that caused concern. So although the risks are currently low, given the constant evolving nature of avian influenza, we felt we should focus on the role of civil society organizations in the event of a future influenza pandemic, because as we learned from COVID and other outbreaks, CSOs play a very important and wide-ranging role in public health emergencies. So we wanted to hear from you, learn what your challenges are, and find out how we can work to prepare together with all partners. So let me start by taking you through the agenda today. We have Dr. Maria van Kerkhoff. Can you see the slide? Who will provide the welcome remarks. Then Dr. Aspen Hammond, Technical Officer for GIP, will provide an overview of the current H5N1 situation and the risk. Dr. Wenqing Zhang, who needs no introduction in the influenza world, she's the head of the Global Influenza Program, will talk about WHO preparedness and response to H5N1. And Dr. Kai von Harbo, the unit head for community protection at WHO, will talk about the role of CSOs in community protection, particularly in reference to what we call HEPA, which is the WHO's Health Emergency Preparedness, Response, and Resilience Framework. Then we have the regional perspective. Christiana Salvi, who's the lead for RCCE in WHO Euro, will talk about the work that has been done in Euro in this regard. So the first part is focusing on WHO, but then the second part of the webinar will talk about CSO aspects. And we're very lucky to have Lisa Hilmy, Executive Director of the Core Group, as well as the co-chair of the WHO CSO Commission, who will give the CSO perspective. And then we have James Ritchie, who's the ex-Assistant General of the International Union of Farm Workers, and also the Workers' Vice Chair in ILO, about who's in the ILO Commission for workers' safety in biological hazards. He's joined us all the way from New Zealand, where it's past midnight, to talk about the perspectives of farm workers and how to protect them. So thank you very much, James. Then we'll have the question and moderated discussion. We'd love to hear from you, and we'll come to the conclusion and based on everything that you've said, some possible next steps. Thank you very much. And now I hand over to Maria van Kerkhoff, Director EPM, for the welcome remarks. Over to you, Maria.
Thanks so much, Supriya, and hi, everyone. Thanks for joining this EPIWIN today. You will probably hear this several times during the course of the next over the webinar, but CSOs play a critical role in a wide range of outbreak preparedness and response efforts. Given the unprecedented spread and the constant evolving nature of avian influenza, particularly the H5 viruses, and the associated pandemic risk, it's really important that civil societies are engaged in preparedness efforts, and we're very happy to have this EPIWIN with you today. During COVID, you have demonstrated such critical importance as trusted local partners in mobilizing communities, delivering essential services, particularly in hard-to-reach areas all over the world. The same engagement is critical in the case of avian influenza, and your involvement will play an essential role in managing risks, educating communities, and facilitating public health responses. Very briefly, because you will hear more about this, I'm sure, from Dr. Wenjing Zhang, the head of our global influenza program. Just briefly on the avian influenza situation, since 2003, more than 1,080 human cases of avian influenza, H5, H5N1, H5N6, H5N8, it might get confusing with all of these different H's and N's, have been reported. This includes the most recent cases as of this month. Since 2024, 95 human infections of H5N1 have been reported. Of these 95, 12 were reported this year. In animals, H5 viruses have been detected in both domestic and wild birds, with spillovers to mammals in many countries and sustained circulation in dairy cattle in the US. Even influenza A H5 viruses has various subtypes. I won't go through all of them. And these viruses are diversified genetically and antigenically. And this means that we really need continued strong surveillance, strong investigations around every human case, but also in the animal sector. WHO is constantly doing risk assessments with our partners and with member states, with our WHO collaborating centers, and we are constantly looking at our preparedness and our readiness actions. When we talk about H5, we can't forget that there are other subtypes of avian influenza viruses affecting humans. These include H3, H6, H7, H9, and H10. And in addition to avian influenza, there's also swine influenza viruses, which pose a threat to humans. So we've said a lot of numbers and letters that are here. And for those of you who don't follow influenza, what is important to take away is that it's important that WHO and our member states remain vigilant around the circulation of influenza viruses, particularly zoonotic influenzas. And we look and we monitor with member states any signals or events that might indicate something is changing, whether we see a change in epidemiology or we see a change in characteristics of the viruses that are in circulation, because we need to be constantly ready should there be an epidemic or a pandemic. We continue to emphasize the value of broad multi-sectoral engagement. We work very closely with WOHA, with FAO, with UNEP, with others who work in the animal sector, the environmental sector, in collaboration of all aspects of response and preparedness for influenza threats. And jointly with our partners, WHO will continue to work with countries on all of these aspects: surveillance, preparedness, response to not only avian influenza, but also seasonal influenza viruses and other zoonotic influenza viruses that are in circulation. I want to take a moment to thank all of my teams here at WHO, led by Wenjing Zhang, who you will hear from, work across the house of WHO, with all of the partners that we have who work on community protection. I know you know many of them through this webinar series. To all of our partners in member states, to all of CSOs who are joining us today, particularly those who are speaking today, and to all of you who are joining, working together on threats like avian influenza is really a strong show of preparedness, a strong show of solidarity against these common threats that we face. So Supriya, back to you.
Thank you very much, Maria. Now, before we go to the technical part of the webinar, we'd like to hear from you. And those of you who are familiar with EPIWIN already know what I'm going to do. So join us at slido.com, #3712545, and we'd like to hear from you. Can you see my screen? Is it showing the wrong screen?
We can see it.
Can you see the Slido?
We can.
Okay, great. What do you think are the different roles, functions CSOs can have in a potential influenza pandemic? Please go to slido.com, hashtag 3712545, and put in your thoughts. Yeah, we see the responses coming in: community-based surveillance, RCCE, monitoring, service delivery, advocacy, coordination, building trust. That's important. Monitoring. Let communities lead. Collaboration with WHO. Case finding, amplifying health advice. Great. Localization of response. This is fantastic. Thank you very much. I will keep the Slido on, so please continue to provide your feedback, and we will incorporate it into when we discuss the next steps. But for now, we will go back to the technical webinar, but please do continue to put your feedback in at slido.com, hashtag 3712545. Thank you. And now I'd like to invite Dr. Aspen Hammond to provide an overview of the H5N1 situation and the risk to human health. Over to you, Aspen.
Thank you, Supriya. Thanks for organizing, and thanks everybody for joining. It's my pleasure to give a bit of situation overview and background that hopefully will help get you the right information and inform some of your work. And it's always good to hear back from you as well. If you go to the next slide, please. I just wanted to give a bit of a background on influenza viruses because probably this is a diverse audience, but just to make sure that we can understand what's important about influenza viruses. They're quite complicated. There are many different kinds. In general, there are A, B, C, and D groups of influenza viruses. Influenza A and B are the most common and circulate, causing seasonal influenza epidemics in humans. So they transmit from person to person in temperate areas, especially in the wintertime. These are the seasonal influenza viruses. But if we look at influenza A viruses, they are also very common in animals. So animals are a host species that is the reservoir for many influenza A viruses as well. So that's what I wanted to focus on a bit as we go forward. Next slide, please. I think the other thing to consider with the influenza virus, it's a virus that is constantly evolving. So it's an RNA virus. It has these two proteins on the surface that we call the HA and the NA. And that's how we differentiate the different subtypes of influenza viruses. So for example, we have H5N1, which probably you've heard of. So there's an H5 protein, and then there's an N1 protein on the surface of these. So these different types of proteins mean all different kinds of combinations of these proteins mean there's quite a lot of different influenza viruses. And again, a key feature of influenza viruses is that they are constantly replicating, and as they do so, sometimes small changes are introduced into their genetic material, which makes them evolve over time. The other important thing about the genetic material in influenza viruses is that their genes are in segments. And this means that there's a possibility if a person or an animal is infected with maybe two different viruses, that there could be an exchange of genes or genetic material, and this could make a new influenza strain arise. And so that's what we have to be on the lookout for. So just again, some key characteristics of influenza viruses to set a bit the background. Next slide, please. So we are focusing on avian influenza here. Avian influenza refers to a disease in birds caused by avian influenza viruses. So avian influenza viruses are a set of viruses that normally circulate in birds. Wild water birds are the reservoir for these viruses, but it happens that the virus can move from these wild water birds to domestic poultry or other domestic birds when these birds are in close contact. And that contributes to the further circulation of viruses in domestic birds and in poultry and chickens. And also, because the virus is in wild birds, and wild birds migrate, we see the spread and the widespread circulation around the world of avian influenza viruses. So it's important, it's a bit of the background on the ecology of avian influenza viruses. Again, we see them in wild birds, we see them in domestic birds. As Supriya said, now we've seen them in other mammals as well. They spread from wild birds or domestic birds into domestic animals as well. And in the next slide, which is a bit the topic of our discussion here, in addition, to make it even more complicated, these avian influenza viruses can spread from animals, so infected birds or other mammals, into people. Luckily, it doesn't happen very often, but it can happen, and sometimes it happens in people, and it can cause very severe illness, even death, when humans are infected with animal influenza viruses. So when the virus is transmitted from an animal to human, then we call it zoonotic influenza. And again, what's important with zoonotic influenza is we see most human cases result from a person's exposure to an infected animal. So the person is likely acquiring that virus and that infection through their exposure to an infected animal. We don't see further spread to the close contacts of an infected person. There have been a few instances where the virus, the infection may have spread to a parent or a relative who was in close contact taking care of a patient, but we don't see continued onward spread from person to person. But it's something that we have to be constantly on the lookout for. And so that's what we mean when we say we're looking for this sustained person-to-person transmission. That would be a warning sign. Next slide. In people, when people are infected with avian influenza viruses, it can cause infection and it can result in a range of symptoms. Sometimes illness in humans can be very mild, so it could be just limited to conjunctivitis or an infection in the eye. It could be a runny nose or a cough, but it can be more severe. So it can lead to high fever, acute respiratory disease, pneumonia, other clinical signs, and again, some cases have been fatal. Rarely, other symptoms, gastrointestinal or neurologic symptoms have been reported. The disease severity in the infected person probably varies on a lot of factors: how much virus they're exposed to, the health of the person, how quickly they get tested and receive care. But again, we see a range of illness, of severity of illness in humans. Diagnosing an infection in a person requires specific laboratory testing. It's not a disease that we can diagnose just based on looking at the symptoms that the person presents with. So testing is done using the collection of respiratory swabs, like the picture shows, although other samples could be collected for the diagnosis. But this is typically the sampling that's done. Probably you're familiar from COVID of a respiratory sample being collected. And this testing is done at labs who are capable of correctly and safely processing and testing samples for influenza infections. Next slide. One thing that is very important to consider, as I said, is the evolution of these viruses. H5 viruses have been around since at least 1996, probably longer, but have been causing human infections since 1997, and since then have really diversified into lots of different groups of viruses. We refer to them as different clades of viruses, and if you follow this closely, you may have heard of the clade 2344B viruses. It's highlighted in red there in the little image in the middle. This is a group of viruses that has really become predominant in birds over the past few years. The image on the top right shows the varying identification of clades of the viruses detected in birds. So you can see 2344 viruses have really accounted for most of the virus detections in birds of H5 viruses lately. And this is one that is now also infecting the dairy cattle in the US, and we see human infections with this virus. So these viruses have evolved over time, again in varying proportions, but we see certain clades that are concerning and that we need to follow. Next slide. So again, these 2344B viruses have really spread to all continents except for Australia, but including Antarctica in the past few years. So geographic expansion. The other thing that's highlighted here on the right side is the number of mammals that are being infected with H5 viruses. So the chart that's sort of in the middle highlights the period from 2003 to 2019. We see a few mammals being infected, but in the past few years, so since 2020, we see quite an increase in the number of mammalian species affected. And this is concerning because obviously there's, the more mammals that are affected, more humans are affected with those different kinds of mammals, the more risk of human infections that we see. Next slide. So speaking of human cases, I just, in the next few slides, give a little bit of an update on the situation in humans. In the past 6 months or so, we have seen human cases with a variety of influenza subtypes. These cases are notified to WHO under the international health regulations, and so we track these cases. So we've seen H5 cases from North America, some from Europe. We see some H5 cases also from Asia, and China has reported H10N3 and H9N2 human infections as well. So we see, again, a variety of human cases with different subtypes from many different countries. This is just the past 6 months. In the next slide, I'm showing also human cases that are infected with zoonotic influenza viruses. This time, this is an epidemic curve showing the time period from 2020 to the present. And here again, we can see we've had cases detected pretty much almost every month in this period. There's a lot of different colors. The colors represent the different influenza subtypes, different viruses. So we see quite a variety of subtypes infecting humans. And again, we see quite a continued detection and reporting of these cases. Next slide. This is a similar epidemic curve, again, of human cases. This is limited to H5 cases, human cases. And this goes back to 2003, as I said. So these human cases with H5 have been detected for many years, pretty constantly in a constant pattern over the years. Most recently, we've seen quite a few H5 cases. Again, a lot of these come from notifications from the United States in people who had exposure to infected dairy cows. Next slide. So in summary of the current situation regarding H5, there have been, since 2003, a little over 900 human cases reported from around 20 countries. Again, most of these cases are resulting from the person's exposure to an infected animal or the environment that that infected animal lives in. Infected animals can shed a lot of virus. And so if a person's exposed to the virus in the environment, they can also pick it up and can be infected. Human infections can be severe and even fatal. We often compare the virus, if we can, compare the virus infecting the human to those that are circulating animals, and often the viruses are quite similar, which is a good indication. Again, there are viruses that continue to diversify genetically and spread geographically. It is a concerning situation, but it's not an influenza pandemic. I focused a lot on avian influenza viruses, but pigs have their own viruses, swine influenza viruses, and those often circulate in many different populations of pigs around the world and can cause human infections rarely, but we do have to keep an eye on those as well. So I think what's important here is that we really recommend that whenever there's a suspected case or a confirmed case, a prompt and thorough investigation around that case are really critical. We really want to identify any situation that might indicate a change in the epidemiology or of the virus, and detect any additional cases so we can make sure people get tested and get treated as they should be. Next slide. So again, why do we monitor these cases of zoonotic influenza at the global level? Again, we want to make sure that whoever might be at risk or infected receives the appropriate care and treatment that they should. We also need to understand the epidemiology. We need to know who's at risk and why, so we can do a lot of the interventions that a lot of you do, the risk communication, the surveillance, the monitoring, providing information so we can reduce risk. We also need to understand how the viruses are changing, and if they are, what we can do about it. Is there change? Are the viruses more easily transmitted? Are they adapting to spread to humans more easily? These are the questions that we have to look at around every case. We also want to know where human cases are happening. We want to try to communicate and work closely with the animal health side so we can prevent further spread and infections in animals and humans. And one of our obviously our concern is we want to prevent any future pandemics. So an influenza pandemic is a risk that we are aware of, and we try to do everything we can so that we can mitigate that risk and respond as quickly as we can. The next slide, please. We assess the public health risk of these viruses using a couple different tools, a couple different methods, which all have their different advantages and uses. One is called the Tool for Influenza Pandemic Risk Assessment. This looks specifically at the virus, and it helps us try to identify what our knowledge gaps around different viruses might be. We do this fairly regularly, updating with new information as it becomes available, and we work to share information between partners and do these risk assessments. We also do rapid risk assessments at WHO, but also with our animal health partners. And we do routine monthly risk assessments for influenza around every human case that is notified to WHO. Important risk questions for us are looking at the risk that additional human cases will occur, but also looking at the likelihood that the viruses might transmit from human to human. Again, this is one of the really critical questions for us. We need to identify if human-to-human transmission is occurring so that we can look at the pandemic risk. All of these risk questions are informed by epidemiology, virology, clinical information, and information coming from different sectors. Next slide. So just some quick results from some of the risk assessments. I mentioned the Tool for Influenza Pandemic Risk Assessment. The outcome of different exercises is shown in the chart on the left, shows all the different viruses that have been assessed, and we can look at their relative risk compared to each other. We publish on our website our rapid risk assessments that we do with our partners. The most recent one is from April, where we assess the current risk to the public as low. Again, the viruses are not transmitting from person to person, so getting the infection from somebody out in the public is low, but the risk is higher, obviously, in those individuals working with infected animals or having close contact with infected animals. Next slide. So that's a bit of the background and the situation, and we'll switch it to Wenqing to talk about preparedness and response. Thank you.
Okay, Supriya, are you going to introduce the Slido or no? You're muted. We cannot hear you, Supriya.
No, please go ahead, Wenqing. The Slido is after this.
Okay.
We'd like to hear from you first. Thank you so much.
Sure. Okay, so please, put on my slides. So first of all, it's really great to meet you all here in this forum. I'm going to spend the next about 10 minutes focusing on WHO's preparedness and response activities. Next slide, please. Influenza pandemic has always been among the top of global public health threats. It is just a reality existing there. But only we don't know whether it will be caused by H5N1 or H5N X. X means it could be H5N8, N5, etc. Or it will be caused by a strain of H7 or H9. It can also come from avian world, avian influenza, but it could also be caused by swine influenza. So we actually unknown. It is unknown which strain will cause the next influenza pandemic. Next. And all these are due to the nature of the constantly evolving virus, because this virus is changing all the time. It causes seasonal epidemics year-round. But from time to time, there's also a pandemic, an influenza pandemic. And always after the influenza pandemic, the virus strain caused the pandemic becomes a seasonal strain and circulated in the population and causing epidemics, and then the next pandemic. So this is type of circle of the epidemiology of influenza. Because of that reason, to address influenza, surveillance, preparedness, and response efforts need to be taken integrated all together at the same time. Next slide, please. So after COVID-19 pandemic, WHO has taken the initiative of strengthening health emergency prevention and preparedness. I guess the next talk will be focusing on this. So specific on influenza, in the World Health Assembly in 2020, this global influenza strategy was introduced, and it takes a holistic and systematic approach to address the problem of influenza. Next. And to address influenza, in the past 70 years, I'm not sure you are aware or not, there's always a mechanism existing on the front of fight against influenza. This is the Global Influenza Surveillance and Response System, GISRS. At the moment, it comprises more than 160 national institutions in more than 130 countries globally. And all these thanks to the enormous commitment from member states, enormous support from international agencies and partners, including you all. Next. So specifically for H5 or zoonotic influenza, there's some aspects of the operation are specific. That is a complementary operation with partners. And those partners, of course, including those from veterinary sectors, including FAO, WA, and OFLU network, but also with other partners like GISET, data sharing platform, academia research institutions. And all these efforts are being made together from the detection of a signal to confirm to confirm whether this is a H5 or zoonotic influenza, to conduct the risk assessment, and then to decide on the response measures. Next. So let's spend a couple more time on H5, specifically on H5N1. WHO has making efforts, and through the global system GISIS, which has been the foundation. WHO has been building, strengthening, maintaining the capability to detect the H5 virus, basically H5 and other zoonotic virus globally, and to conduct the risk assessment. There are some of the routine or every year or year-round activities. For example, the annual EQAP to make sure that the countries globally can detect a virus and a muted or circulating viruses, updated laboratory protocols, updated reagents. The GISRIS network also facilitating virus sharing so that those viruses shared can be characterized in depth in WHO collaborating centers, which actually forms the base for risk analysis and risk assessment. And again, these efforts have been made jointly with OFLU and other academia institutions. Next slide, please. So on the H5 risk mitigation, our partner agencies, FAO and WHO, have published its global strategy for the prevention and control of avian influenza. And specifically, I want to highlight the biosecurity recommendation as well as strengthening surveillance indeed, because viruses in the animal sectors, they are the source of human infection indeed. Excuse me. And then at the human-animal interface, WHO provides the guidance for people with occupational risk, and also provide guidance on surveillance specifically towards H5. If an outbreak occurs, then there's guidance available to countries about how to conduct investigation, how to respond to the outbreak with a whole package of practical information available. WHO also provide clinical practice guidelines for influenza, and in the past many years, risk communication, is a very key component in the response to H5 outbreaks. Next slide, please. Now, this slide is specifically on H5 vaccines. So as you know that the virus is constantly evolving. An effective vaccine needs to contain the right viruses within the vaccine itself. And this requires WHO update the candidate vaccine viruses that can be used to develop and produce those H5 vaccines. And so far globally, there are H5N1 vaccines being developed using the candidate vaccine viruses from GISRIS and have been licensed for use in an influenza pandemic situation and in several countries. With regards to H5 vaccine stockpiles, some countries stockpile these vaccines as part of their outbreak response or pandemic preparedness measures. WHO does not. We don't have a stockpile of H5N1 or other zoonotic influenza vaccines. With regards to use of H5 vaccines, WHO provides scientific-based options for countries to consider regarding the use of H5 vaccines at inter-pandemic period means now at non-pandemic period. And the decision actually to use H5 vaccines depends on individual countries' risk-benefit analysis. And as you know, some countries, actually only one country decided to go ahead use of H5 vaccines for the time being. Next slide. So for the previous slides are specifically on H5, but as I said, for preparedness, For the next influenza pandemic, there are a lot of measures being undertaken for H5 and non-H5 pandemic influenza, and that includes the surveillance. So WHO at the moment are updating us guidance on surveillance during an influenza pandemic. What actions need to be taken by whom, what information should be shared with whom, etc. Also, the public health social measures, previously called non-pharmaceutical intervention guidance, are being updated. On the pandemic vaccine response, especially at the very beginning, when the seasonal vaccines are being produced, but an pandemic occurs, or how to respond most efficiently and effectively, they need a globally coordinated effort, and this would be guided by the PIWIN guidance. Of course, there's a pandemic influenza preparedness framework. PIP framework has been adopted by the World Health Assembly in 2011, and it provides the guidance about sharing of viruses and access to benefits, and it improves to ensure the equity, of access to those products. And also to respond to the next influenza pandemic, this interim medical countermeasure network is looking at the access aspects, where to improve the equity of the access. With regards to national pandemic preparedness planning, WHO working at all levels of HQ, regional offices, and country offices, helping countries to update and develop their planning. But also, it's not just a plan, a document, but also the actual capacity being built through the seasonal influenza, through the zoonotic outbreak before a true pandemic occurs. And the partners' engagement, including like the webinar here with the civil society, this is again part of the overall preparedness efforts that WHO has been making. And beyond those, there are a lot of more efforts that the WHO has been making jointly with its member states on the broad pan-respiratory all hazards preparedness efforts going on. Let me just pause here and back to Supriya.
Thank you very much, Wenqing, for that very comprehensive overview. And with that, as Wenqing mentioned, one of the key roles is of partners. And I'd like to invite Dr. Kai von Harboot to talk about community protection with partners and CSOs. Thank you so much, Wenqing, and over to Kai.
Yeah, thank you very much, Supriya. Just to confirm, can you see my slide?
Yes, we can see it. Thank you.
Great. Thank you very much. Also, thank you to Maria, Wenqing, and Aspen for these great presentations. And also from my side, I really look forward to hear from the regional colleagues, and then in particular from our partners, the CSOs in this context. My name is Kai von Harboot. I'm the Unit Head for Community Protection and Resilience here at WHO Headquarters. And I will just take a few minutes to speak a bit on the importance of meaningful partnership with civil society organizations in health emergency management. And of course, we talk in particular about the context of Asian influenza, and also how we as WHO here at headquarters are supporting this process. And I think that many of you are already familiar with some of our core concepts on community protection. And one of the most important is that communities are not just beneficiaries, they are the first responders. And that means that they are able to detect outbreaks early, they are key in responding effectively, and to maintain essential services at the local level. And in particular, this is most pronounced in a global pandemic. It's a real key lesson learned from COVID-19, where we have limited international response resources available. But we are seeing this again and again in any other emergency as well. We've seen it now in Mpox, in cholera, Ebola, earthquakes, conflicts, displacements, and no matter what kind of emergencies, communities are the first responders, and also the last responders, really, the ones that are providing services when all the international mechanism has already moved on to the next emergency. And that's why WHO has embedded community protection at the center of our HEPA framework that was mentioned already today and that many of you are aware of. And we as the community protection unit are really committed to translate this into practice. And this is what we want to do in particular with civil society organizations, because their role is absolutely vital across all these three objectives of our community protection framework that you see here on the screen and that many of you may be familiar with. Because civil society organizations are central in effective communication strategies that were mentioned already quite a few times, on building trust, on addressing misinformation, which continues to be a growing challenge, of course, in many emergency settings. But they are also a key service provider ensuring equitable access, with a focus often on the most vulnerable migrants, informal workers, and others that face systematic barriers for access to services. And of course, CSOs are contributing to health workforce strengthening, to supporting community-based surveillance. And it's really great to see that this was one of the first words that popped up in the word cloud in the beginning, and in protecting communities from the socio-economic impacts of emergencies. And that's the third objective of our framework, focusing on. That's a key aspect as well. And of course, you as civil society organizations, you can reach communities where others cannot. You can bring the local context, the knowledge about the culture, the lived realities to the table. That's really, really central. And you can bridge in that way between the government and the communities. And we really want to support that this is kind of, this is translated into realities on the ground. And based on this, this recognition of the importance of civil society organizations, we as a community protection unit and WHO began systematically engaging with CSOs during COVID-19. And last year, we established a global engagement mechanism building on the EPIWIN platform to continue and expand this to a regular dialogue and information exchange with CSOs at all the different levels. And this we have used in particular quite successfully in the mpox response, and many of you may have been a part of those meetings as well. And we are now finalizing a framework for CSO engagement in health emergencies, which you can see here on the slide, which is based on a 10-step process to help our member states, but also our own WHO staff and partners to engage systematically and meaningfully with CSOs. And that starts with the mapping of the different actors, defining the roles and responsibilities, establishing sustainable coordination mechanisms, information sharing, capacity building, etc. And this is really a process about aligning our efforts among partners and co-creating solutions between the different stakeholders, which is essential not only in the emergency response, but also for strengthening long-term resilience, which is a key aspect of our work as well. And this is so important also in H5 and avian influenza. And here are some examples of the key roles of CSOs in this context. CSOs are supporting poultry farmers in awareness raising about safe practices, and we will hear some very strong examples on that later. They're supporting community health actors to monitor symptoms and refer early. They are faith-based and migrant-led organizations that work on creating trusted spaces and counter misinformation. And some of these examples we'll hear later. And these are really the mechanisms that are existing that we want to strengthen. This is not so much about building new mechanisms. This is about building capacity and strengthening existing mechanisms and embed them in the national and global preparedness strategies to ensure that the voices of CSOs and their communities are heard and their capacities are integrated. So that's just a very brief snapshot. You can see here on the slide some links to more information about our work. We will also have a side event at the World Health Assembly that I hope many of you can join, which is also will also be able to follow this online. And with that, I hand back to Supriya. Thank you very much.
Thank you very much, Kai, for outlining the work in community protection and how CSOs are integral to that. And as Kai said, we hope to see you in the World Health Assembly side event as well. So please do register. Now, you've heard from our technical team about community protection. We'd like to request Christiana Salvi to give us a regional point of view, because every WHO region has been working to work together with CSOs. Over to Christiana for the perspective from WHO European region.
Thank you. Great, Supriya. Can you confirm you see my presentation?
Yes, we can. Thank you.
Perfect, perfect. So I will be brief. I know we are over time. This is basically to zoom in what has been already said, particularly by Kai, when he was presenting the work within community protection, which is at the center of the emergency framework in WHO. And here we're looking specifically at risk communication, community engagement, and infodemic management, which is at the heart of community protection, like Kai was mentioning, in the context of H5N1 readiness. We know that in the European, and this is basically the outline of this presentation, and if I don't manage to go in depth about many of these issues, I will be happy for the presentation to be shared. So as I mentioned, in Europe, we are at the readiness stage. We have the luxury to do so. We didn't have this luxury with COVID-19. I mean, we know that basically started in Asia, and then after a short while, we'll had it in Europe, and we had immediately to respond. Of course, we don't know whether H5N1 can be the next pandemic, but we still have the time to prepare to be ready for any possible human-to-human transmission, and in case, I mean, it develops further. So what I will basically detail the steps that we have been taking in the European region to prepare, to get ready. So first of all is a short guidance on focusing on H5N1. And this basically was developed when basically we started to see a change in disease occurrence and transmission in the USA. And again, we wanted to really prepare. And I also want to say that this is also based on some of us experience. I was particularly engaged in the outbreak in 2004, 2006, in Europe and in other parts of the world. And so there is a lot of that experience that is also into this. So there is a very short guidance, basically focusing on what are the critical interventions to be taken in RCCIM, with particular focus on targeted diverse audiences, because of course we have the general population on one side, but we also have at-risk groups that needs to be targeted, as well as health workers that would support particularly the detection of H5N1. It was said before by Dr. Amon that we can't identify H5N1 by clinical symptoms, so we actually need the laboratory testing to do that. Then coordination between health and agriculture, because we know that this can become a political element. We know that different sectors can say different things to save a livelihood or to save the health. And so we need to have this consistent approach within One Health. And then the ability of speaking in uncertainty. We don't know what will come next. We know what is the current epidemiology, but we don't know what can happen. And so we need to be able to provide risk communication in the context of uncertainty. This is based basically on 3 scenarios that were developed in our region, not specifically to RCCIM, but to the broad response. The scenario A is a change in the level of risk, also based on what is happening in other parts of the world. Scenario B, starting to see human-to-human transmission, and scenario C, sustained human-to-human. We are now in scenario A, where we basically see that the overall public risk is low, while we see that the risk to those exposed to infected animals on contaminated environments can be low to moderate. And this is what we have been done so far. So establishing social listening system, developing and testing health information and advice, detecting and respond to false narratives, mapping community stakeholders, and this is what really comes very to the point with this audience, and then provided advice on how to coordinate between health and agriculture. So I go a little bit in that. So this is what we have been seeing in context of social listening between March and August last year. And then we stopped basically this effort because we were seeing repeated findings. The main findings in the context of H5N1 was the potential to become a next pandemic, the need of strengthening surveillance, the effect of H5N1 on the food industry, the human cases in the USA, and the vaccination. And then some findings on false narrative, which is mostly about conspiracy theory being manufactured, the big pharma interest, and WHO trying to spread fears. This is basically a toolkit, a number of tools that we, particularly tiles, that we have developed for different type of groups. The one for the general population was released last year because there was a basic heightened attention of the population in Europe, and particularly there was perception of a high risk, why, as we saw, the list to the general population in Europe particularly has been consistently low. Then we also developed two sets of tiles that we haven't released yet, but we are keeping them ready in case that we are seeing developments. One to farmers associations and civil society organizations working with farmers, and another one for health workers, particularly to support testing based on case definition. So this is basically an overview of what we did, what we already released for the general population about what it is, how can I catch it, what are the symptoms. We really needed to reassure the European population that this is not something that would cause a threat at this stage, but we wanted to make them understand why there was so much circulation on this on the media and what it means for them. And then about message testing. So we tested the messages for the general population. There was a sample of about 200 people English speaking. And there was basically what we saw, that the majority was not concerned about influenza, avian influenza, but still the majority of those who were not concerned agree that they will seek medical advice after viewing our advice. So this was a very important insight that we got. And also that the messages that we were sharing with them to be tested were pretty much clear. This is a slide, and I'm getting to the end, about the community mapping. This is mostly relevant to you. So what we have done, working particularly with our country offices and other civil society organizations, we identified 31 community groups that we want to engage with to test particularly the health advice to the specific at-risk groups, but also to co-design our intervention. So we would also pick up your interest through this webinar if you are interested in working with us. And then, of course, we want to build on this for the next phase of the readiness and response. And this is it. I hope I was on time, and I would be happy to answer any questions. Over to you, Supriya.
Thank you very much, Christiana. And thank you. That's a lot of work. So thank you for sticking to the time as well. Much appreciated. Now we've completed the WHO part of the webinar. I'd like to invite Lisa Hilmy to talk about the CSO part. And just before we start, I'd just like to request all participants, I know we're running well beyond schedule, so if you could stay on a little longer, it would be great. And is that okay for you as well, Lisa? And I don't know about Jamie because it's past midnight in New Zealand, James, but would it be possible to stay on a little longer?
It's fine for me.
Thank you so
Yeah,
much.
thank you. And thanks, James. New Zealand's a tough call. I remember a lot of calls during the pandemic with New Zealand. So thanks a lot for staying up. So thank you, everyone. My name's Lisa Hilme. I'm Executive Director of Core Group, as well as the co-chair for the WHO's commission. I'm very excited to be here together. And I'm very, grateful to WHO because we know that engaging civil society is so important before an outbreak happens. And so thank you, and I congratulate WHO and Dr. Supriya for this webinar, and I'm sure a long series of collaboration that will happen. A quick promo for the WHO CSO Commission. The mission of the WHO Civil Society Commission is to strengthen dialogue, foster collaboration, and provide recommendations to support WHO on its engagement with civil society at the global, regional, and national levels. And this is really to achieve health for all. And somebody has their, Michelle, yeah, thank you. And this is really to achieve health for all and the objectives of the WHO General Program of Work. The goal is to ensure that civil society's voices are available to WHO, and it's a bi-directional relationship. We have a steering committee. We just had the general meeting and working groups, and we're also committed to be working at the regional and country levels. So please consider joining and getting involved. If you aren't already part of the commission, we'll put the link into the chat box so you consider applying. So back to avian influenza. We've heard a lot today from our colleagues at WHO how civil society can play a crucial role in avian flu prevention, preparedness, and response. And we're not just talking about advocacy. We've heard about surveillance, community level action. And it's important that we engage civil society prior to emergencies. I'm sure many of you remember during the pandemic where civil society might have been brought in later. So involving civil society in decision making, in strategy formation at the country, regional, and global levels is key. We know that trust has come up again and again, whether it be COVID or Ebola, or really any outbreak in the community. Trust in the community depends on civil society, as well as working in some of these areas where governments can't reach. Civil society is there, especially in remote areas and fragile states. And so I want to give you a couple examples, as well as ways that civil society has been key in past outbreaks, but also for prevention for avian influenza. We're talking about the public awareness and education. I'm happy to see from our colleague the messaging for the public, but it's the dissemination of those accurate information where NGOs and community groups can be very key in educating the public. The promotion of safe practices is also important for how to handle or cook poultry and discourage the sale of the consumption of the sick or dead birds. And then what I consider, so important is community-based surveillance and early detection, because it's really the local organizations that can help monitor outbreaks amongst birds and report some of those unusual bird deaths to authorities. And that's where the collaboration part with different ministries besides health ministries comes in. They can also crowdsource data. And so, for example, in Nigeria right now, we know we have avian influenza surveillance happening at the community level. We have been working with the Among Poultry Farmers Association, in which some of the key informants who report cases of poultry and signs and symptoms of avian influenza, they report to veterinary officials and then can confirm cases. Because sometimes avian influenza is confused with Newcastle disease in poultry. We also know that civil society and private sector have to work together in some of this surveillance, and where civil society trains community members to keep poultry at the small scale on recognizing in AI, keeping their premises clean, especially for some of those big scale poultry farms. And I'm really happy that James will be talking about the farmers, because these farmer networks and some of the behavioral change and the decisions that farmers have to make is so difficult. And that's where civil society working on health issues it's so important to integrate with farmers and farmers associations. We have the policy and the advocacy piece with government in terms of investing in veterinary services, the preparedness, and public health infrastructure. And that financing around policy engagement and financing is so important. If we aren't allocating funding for the preparedness of avian influenza and other outbreaks, then we will not be successful. We will be short on funds. And so civil society has great roles in promoting and advocating for financing for future pandemics, but also outbreaks. And civil society has helped as well as supported vaccination campaigns. We also know that at the home care, at the home level, and it's really a gender issue, because a lot of time it's women that are preparing food, preparing poultry for eating. And so bringing in women to the discussions, having women know about the signs and symptoms of healthy or sick poultry, as well as the hygiene materials that might be needed for vulnerable populations. So let's not forget that there's a gender component that civil society can really work with, as well as some of the behavioral change initiatives. And we've talked about fighting information and misinformation, controlling those rumors and fear. We know from not only the pandemic, Ebola, Marburg, so many Mpox, that fighting this myth and misinformation is key, and getting the correct messaging. And civil society, having built trust with religious groups, with radio, and more, can be really instrumental. So that collaboration has to start now. So I see all of you attending this incredibly important webinar as a very important first step. I could give examples, but I think right now we're short on time. We want to get to your questions, and I want to make sure James, who brings in the farmers piece, that he gets a chance to present that, because that's so important. We're really excited to collaborate with you, not only from the WHO CSO Commission, but bringing civil society's expertise and their already important trust in the community to this conversation. So thank you very much. And I know that the slides will be shared after the slide authors and presenters approve that. So I'll stop for now. I hope to hear from you and your questions. And back to you, Dr. Supriya. Thank you.
Thank you so much, Lisa, for that very comprehensive overview of the role of CSOs, which you made so concisely and clearly. That's really gives us a very good sense of the vast role of CSOs. Now I'd like to invite James Ritchie, all the way from New Zealand, to talk about the farm workers' point of view, the workers' point of view.
Well, thank you very much, Supriya, and thanks very much to the World Health Organization for very informative presentations that have been given. Thanks also particularly to Lisa for her presentation. It was certainly, all of those issues resonated very strongly with me. I'd like to just lead in by giving a bit of a background about why I'm here and how I got involved as one part of civil society in the very important work of protecting communities against not just avian influenza, of course, but all kinds of viruses that increasingly circulating in our communities. So during the pandemic, I was working for the International Union of Food Workers. I was based in Geneva. I'm now trying to retire, not very successfully, back in New Zealand, but I was in Geneva at the time. And the thing, immediately we had to work out ways to protect workers from the COVID-19 or during the COVID-19 pandemic. And in particular areas, the virus circulated in much more strongly than it did in other areas. One workplace was meat processing plants. And we worked with the World Health Organization, with epidemiologists, with David Nabarro, with a whole host of people to try and put some science into this situation and figure out how we could best protect workers. And I won't go into all of the details. And we did the same with hotels, and we did the same with a lot of other industries. But the issues around trust are so important. What we found was where there was strong relationship between the employer and the trade union, and trust was built up within the workforce around that relationship, then there was much better uptake of vaccination. There was much better uptake of the particular health and safety mechanisms that were required to protect workers and so on. So it is that engagement is so important, that planning is so important, and the ability to keep communicating and to keep building organisation which is able to protect workers and therefore protect communities is so important. So just to, before I get on to, and I will get on to farm workers, but one of the things that work has led on to has been the work that is being done right now at the International Labour Organization to negotiate an international convention and supporting recommendation on protection from biological hazards in the working environment. And that process started at the International Labour Conference in 2024. It will be concluded in the first 2 weeks of June this year. And I have the honour of being the workers' spokesperson in those negotiations with governments and employers. And we hope to add to the international standards, and this is very important, the standards within occupational safety and health have to complement standards in public health. And the public health, occupational safety and health interface is critical in protecting communities from circulating viruses like avian influenza. So it's sometimes the source of the hazard is in the workplace. Sometimes the source of the hazard is outside the workplace, but regardless of the source of the hazard, it has to be managed when it is when it exists in the workplace. And if it's not managed in the workplace, then it can't be managed in the community, because people go to work, come back to work, and particularly we found during the pandemic, essential workers, critical workers had no choice but to move from workplace to the community. And so that was a very important area to try and manage this. One thing that I think is absolutely critical in addressing the spread of avian influenza or any other virus is the ability of workers to feel that they have income security in any of these situations. The income security comes from adequate paid sick leave that is provided either through legislation from governments or provided by employers through negotiation with their employees. But if a worker has the choice of going to work when they know they're infected with an infectious disease, going to work, because if they don't go to work, there won't be food on the table for the family, and important living conditions will be deteriorating. So poverty, if poverty is driving people to work when they shouldn't be at work because they're infectious, then that is a public health issue, and it's an issue that's for all of our communities. So I think that needs to be emphasized really quite strongly. To turn now just to the situation with avian influenza, it is the occupational groups at risk, most at risk, of course, poultry farmers and poultry workers. And particularly as poultry is generally grown for commercial use these days, and that is in intensive livestock production. And those people who work in those chicken houses are exposed to all kinds of viruses all of the time, as well as significant dust hazards and so on. And unless they have appropriate protective equipment, then they are exposed. And personal protective equipment must be suitable. It must do the job. It must be appropriately fit the worker. It must be gender sensitive, and so on. So this is something that there's a lot of work still to be done with employers, with governments, and of course with workers, to make sure that workers are protecting themselves properly with personal protective equipment. The same with the outbreak with dairy cattle in the United States. Again, it's been very slow, the uptake of the use of appropriate personal protective equipment for a whole variety of reasons. Now, in agriculture around the world, millions of people are employed in agriculture around the world. Some of those people are employed in livestock production, and this is the highest occupational incidence of child labour. It is the highest incidence of low-paid labour and poverty around the world. It is one of the ironies that the people who feed the world are often some of the poorest people, poorest workers in the world, and small farmers as well. So it is a huge, mammoth task to get the message through communities, and civil society organisations are absolutely critical in this. Faith-based organisations that support migrant workers, and trade unions all have to work very hard at protecting workers in this area. These workers are usually workers in dairy cattle farming in the United States, in poultry farming around the world, are often migrant workers. They're often very vulnerable workers, and they will not put up their hand for personal protective equipment. They will not put up their hand to identify hazards and try and make their workplace safer, because they're often terrified of losing their employment, or they're terrified of being deported out of the country in which they're working. So perhaps that's a bit of a very general overview, but perhaps I can just pause there and we can move on to the question and answer session. So thank you very much.
Very much, James. Once again, very interesting, very, very relevant insights overall with the work that you're doing with ILO, some key points there, as well as work with the poultry farmers, talking about, well, the key thing, what sticks to my mind is, protecting the workplace, whether the hazard is in the workplace or out of the workplace. Very, very critical there. I will now go on to some of the questions that are coming out. So everyone here, please do put your questions in the Q&A for the panelists to talk about some of the issues that you're talking about. The first question we have is Dorcas Sherbet Juma from Pwani University. She says it's located at the heart of Mijikenda community. Besides being a cosmopolitan and tourism area, the strength of the institution is community engagement with a faith-based approach, but they'd like to give guidance on direct engagement, especially through Ministry of Agriculture. So my question then to the panelists is, how do community-based organizations get involved with the state or national governments? And as Lisa said, it's not always necessarily the health ministry as well. It could be the Ministry of Agriculture and other ministries. Any thoughts on that to any of the panelists? Let me start perhaps with James, because you've been working with workers and agricultural things.
Well, I think it's critical that that civil society organisations make contact with the competent authorities in the national jurisdictions within the state system. So there's always competent authorities around public health and around epidemiology and so on. And so gathering information is incredibly important, and also to make the competent authorities aware of the situation on the ground, what the reality is for farmers and farm workers who are exposed to avian influenza or any other infectious disease in a situation. So I think that active engagement is so important, and not just a one-off active engagement, but setting up that continual dialogue through a situation so that the communities can be protected and involved as much as possible. And of course that builds up trust as well, and tries to counter the conspiracy theories. Thank you.
Thank you. Lisa, would you like to add anything as well, your perspective on that, from your experiences with avian influenza in the community?
Thank you very much. And so this One Health animal-human interface discussion, collaboration, and technical guidance, similar to James, what he said, it has to be a regular dialogue between not only civil society, WHO, ministries of health, ministries of animal welfare, veterinary. But for avian influenza, we have to bring in the farmers groups and the private sector. And in order for them to be accountable, as well as on board with this strategy and risk mitigation, we're not only talking about the prevention, but God forbid, if there is a response, as we know in 2006 and 2007 in the 2000s, and even some of the confusion happening with other diseases that might appear as avian influenza, this quick type of collaboration, communication about possible suspected outbreaks, and really technical guidance has to be established. So even with those ministries and civil society and private sector, that trust has to be there. There's some great examples in Horn of Africa where they're using WhatsApp to monitor different cases for One Health, whether it be rabies or anthrax, avian influenza, as well as polio outbreaks. So I think there's a lot of learning, but collaboration is key.
Thank you. That's the take-home message. Collaboration is key, with so many different sectors working here. We have another question here. How can community-led monitoring mechanisms be formally recognized and resourced as part of national pandemic preparedness and response plans, especially in low-resource settings? Kai, is Kai there? Or Christiana?
I can take it. I
Yeah.
see Kai was there, but I can
Okay.
start. I think that this connects very well to the previous question. I think that we really need to work together collaboratively on both top-down and bottom-up approaches. This integration is fundamental in the sense that, and this is something that WHO has been doing consistently, I mean, at least for the last 5 years, working with governments to make them understand what are the benefits of working with communities and the civil society organization as a bridge between the health authorities and the communities, exactly to bridge this, build this trust. And then working directly with the communities and the civil society organization to implement the projects at the ground level and to show the result. So it's actually a virtual circle that needs to be put in place so that we make clear that there is no other way to address any response without the engagement of the community actors on the ground. So maybe I can also elaborate on this, but I think Kai is on board, or maybe you want to take it from there, Kai.
Yes, thank you. Apologies, Kai. I somehow didn't see you, but
Sorry, no,
over to you.
Yeah, thank you, Supriya, and thank you, Christiana. Just to add a very few points on that, and I think also the question before, I think these are all the points that we are really advocating for. We want to have that shift from community-based organizations being treated as beneficiaries or implementers only and to true partners. That's our key message that we have, so that we also shift the funding structures away only from national and big partners in the capital cities to really field-based response. That's a very, very important shift that we are promoting towards the community-based actors as kind of the first line of defense and the first line of response. And we are really advocating in many meetings, etc., with donors on that there's dedicated financing mechanisms, such as a pandemic fund, that they integrate and earmark portions of the resources towards community-based organizations, and in particular to the community engagement activities around it. That's really, really key. And also in the 10-step process that I mentioned, we advocate for formal mechanisms to channel funds from the national response mechanism to community-based organizations in the response. And we also, of course, embed community engagement in many national preparedness frameworks through mechanisms like the National Action Plan for Health Security, etc. So these are all very important mechanisms that have to be strengthened. And then also what is really key for us and also for our partners, the CSOs, is that we document the impact. And I think that's very important when it comes also to the community-led monitoring that was mentioned. So how can we gather and share evidence of how these community-led initiatives actually drive impact during emergencies? That is something that we also try to focus on more to really give kind of the visibility also to our partners, especially right now where there's in this resource limited setting that we're facing at the moment. That's a few more points from my side. Back to you, Supriya.
Kai, thank you. A very critical point there. We have to document to show impact, and that can have its own impact. We have a question also on the impact on community for, well, the other one is Charlene Turner, is about how we can protect farm workers who may be frightened to request PPE, safe working environment, keeping their job and reporting illness. From your experience, James and Lisa, have you had experiences where this has happened, and how have you, do you know how this situation was addressed? James first, perhaps, or Lisa?
Oh, just in very general terms, I think, as I said before, I think that it is civil society organizations have to put pressure on the particular government departments, whoever it might be, perhaps it's the Labour Department or Occupational Safety and Health Department, to go into the field and talk to employers about their responsibilities to protect workers from the hazard. And that has to be kept away from any involvement by immigration authorities or anything else. So how do we, I think the question that we all have to ask ourselves is, how do we overcome the fear of that a worker has of losing their employment, or worse, losing their employment and being deported, which prevents them from putting their hand up and asking to be protected from the hazard. And every sort of community effort from trade unions, faith-based organisations, migrant workers organisations and so on, all have to try and coordinate and work with the appropriate authorities, government or state authorities, to try and break through that particular barrier.
Thank you, James. This coordination is coming up as a very key word here. Lisa, over to you, and then Christiana has her hand up. So Lisa, then Christiana.
Yeah, thank you very much. And I think it's important to realize that these outbreaks hit countries regardless of income level, regardless of stability of government, and that sometimes the political pressure and civil society, they have to work together. So having this dialogue with even parliamentarians and state representatives, whether it be at the regional or state district levels, is really key. And so I always encourage not only working with parliamentary unions, they often have a health focus, and again, doing this ahead of time, ahead of outbreaks, but also people and civil society have a huge impact when their voices are elevated in terms of accountability and also changing political will, and to have them prioritize things for policy. We're learning that in the United States right now. And so I really strive that accountability part has to involve parliamentarians and political actors, as well as health workers and community workers. I think that way you can have better success in changing minds as well as elevating policy.
So I think it's me, Supriya. So I just want to make a very stronger the point of the fundamental importance of the agriculture and the health sector having a unified strategy. I saw very clearly, I was a part of the outbreaks in Europe in 2006. I mean, the two sectors, when they're not together, first of all, there are inconsistent messages out. I mean, maybe one sector supporting the livelihoods and one sector supporting the health. And of course, like what James was mentioning, when a farmer is seeing basically his economy falling and being under threat because of a health risk, maybe they will not prioritize health. They will prioritize their livelihoods. And I've seen flocks of poultry being culled because of avian influenza, but without information and without incentives. So we really need to have a unified strategy here between health and agriculture, because that will give the consistency of intervention, but will also support the health basically element above the economic element when basically people are protected economically. So this is something that is fundamental, and how us as basically or international organization and civil society organization can advocate for that, as Lisa was mentioning, in name on One Health. And is also basically gives us the foundation to strengthen the One Health approach also for the future. Over.
Thank you, Christiana. A very do this. My microphone just got muted. Apologies for that. We've just over time, but we have another very important question. This is on community-based surveillance for avian influenza. It's from Siti Lutvia Frahmani. How can CSOs effectively support community-based surveillance for avian influenza? I'd like to put that question to Kai and to Wenqing.
Thank you,
Kai.
Supriya. Maybe I start briefly and then I hand over to Wenqing. So from my side, what is important is that we recommend the involvement of CSOs not so much in an ad hoc manner, but more in an institutionalized participation in community-based surveillance. And in particular, it has to be as part of a national surveillance strategy. That's what we are really supporting. And for example, for MPOX, we have developed standards for community-based surveillance together with IFRC, who are a very important actor in this. And I think we can share that probably in the chat. Of course, CSOs, especially if they have a significant community health workforce or volunteer base, they can really be the intermediaries. They can transmit the alerts when they are properly trained and when they are part of a structured reporting mechanism. That is key. And that's really what we want to see as the role of the national public health authorities and the Ministry of Health, to develop a national mechanism to not have too fragmented approaches when it comes to community-based surveillance. And for that, we are providing training and digital tools, etc. And then CSOs can really be embedded into a mechanism that mobilizes many different community networks, looking at really also different at-risk groups in particular for the reporting purposes. That's from my side, and I'm sure that Wenqing has a lot to add to that. Over to her.
Thanks, Kai. Wenqing?
Yes,
Kai.
actually, yeah, I've been listening to all these discussions. Actually, they are all connected. The core topic is that how actually we could recognize the importance of civil society and the activities at the community level. And I would want to say is that in the past few years, the importance of the community-based activities, like a community-based surveillance, actually has been taken into consideration more and more seriously. One example is that at the moment, when we build surveillance capacity in countries, we use a tool called Mosaic tool. There are different mosaics. And one of the mosaic, actually, it is community-based, and even we going down to even more details of those different surveillance types. So it is being recognized officially or formally when we are building this capacity in country. Another comment is that in the national pandemic preparedness development, more and more, it is taking, the approach has been taken is a whole society approach. It's no longer just limited to those traditional areas of the work and the response. It's very broader. And again, it's like even the ministry, it's many ministries, they are sitting together. So the earlier question from Mexico, for example, there are strategies and the national plans existing in Mexico, and they've been conducting exercise. And through those components would be able to be incorporated formally, as a preparedness component. And with these, like funding, etc., because funding always connected to the exact activities and the deliverables, etc., would be more and more recognized by those decision makers. So maybe this is all what I would like to add here. Back to you, Supriya.
Apologies again. It seemed to be muted all the time this time. Thank you very much, Wenqing, for that and for sharing, for example, the work with Mosaic. And Kai has also shared on the chat the interim guidance for strengthening community detection and response during the mpox outbreak, which gives an examples of community-based surveillance. And the role of CSOs also in there. We are now 11 minutes over time, but we do have one question on examples, effective strategies for reaching the vulnerable, which is something that CSOs do, particularly in fragile countries. Would any of the panelists, I'm not going to pick anyone would like to take that on? Effective strategies for reaching the vulnerable? Yeah, Lisa.
Yeah, thank you very much. So when I think of underserved populations or vulnerable populations, a lot of them are in remote areas and war zones and conflict, cross-border, remote pastoralists. And sometimes access can be really hard. So there always has to be some type of negotiated access with local leaders. Sometimes it's religious leaders, sometimes it's non-state actors, to ensure safety of not only the teams that are going in to reach the populations that are underserved, but also for the protection of the people that are in those communities. So really having a risk mitigation plan, which involves a security plan for reaching those populations through negotiated access sometimes. We've found that has been very effective, and it's also something that civil society and even governments don't always have training in. We implemented that as part of a Gavi program, and folks found it extremely useful in order to gain trust and have those populations, because once again, it goes to trust, and it goes to really having a clear, working with local leaders that they understand the purpose. Thanks.
Thank you, Lisa. I'm very conscious now that we're well over time and keeping everyone well beyond what they hoped they would be here, but this has been extremely interesting and important. What we will now do is collate all your questions, try to respond to them, to as many of them as possible, but we will also this will also inform what we hope we'll take forward as a way for working together with CSOs for potential pandemic influenza preparedness. So thank you for your inputs, and we think this is just the beginning, and we will continue the dialogue. So thank you very much for joining. And Kai has also put in the chat, so please look at it. There's a WHO side event on the 22nd of May on community protection, including civil society. So please do join. I will also share that with all attendees later on through email, but please do join. And thank you very much. Thanks to each and every one of the speakers, particularly I will start with James because he stayed well beyond midnight. He agreed to speak at very short notice and has stayed well beyond midnight, so really appreciate that. Thank you also to Lisa, also agreeing at the last moment, bringing in her valuable experience from not just the core group, but also working on avian influenza. Thanks to Kai, he's my supervisor. He's also the unit head of community protection. And so this is very, very relevant. Thanks to Wenqing, who's leading an influenza, global influenza program and critical, and her team. Aspen, who gave that wonderful presentation, and Vanessa, who's not here, but who was helping in organizing the meeting. Thank you to Christiana. Thank you for volunteering to share with us all the work that's been done in Euro. And to everyone behind the scenes, my colleagues at Project ECHO, but most of all, thank you very much to all the participants. Oh, also, I would like to thank Sarah Hess and Sally Smith, who I think I saw in the who also joined. Thank you so much for joining and for your support with this. Sally Smith and Sarah Hess lead the Faith Network and Health in the World of Work Network for WHO. And finally, the Civil CSO, WHO CSO Commission and Michelle, they are key to civil society engagement with WHO, and we couldn't have done it without their support. And thank you, and see you soon, I hope. This is just the beginning.
Thank you. Bye-bye.
Thank you. And thanks to you, Supriya, for the great moderation. Thank you, everyone.
Thank you.